is a microphone up here. If you have a question for one of the panelists or more than one, please come up, give us your name, and ask your question.
I'm Marianne Hansen, and I have a question that I'd like to direct to those of you who are advocating personal responsibility. I just wonder how we can expect people to take personal responsibility to become informed consumers and make informed decisions about a lot of these issues when we know, for example, as you pointed out, that a huge percentage of the population doesn't even understand that antibiotics only control bacterial diseases. I personally have a background in biology, and my husband was diagnosed with rheumatoid arthritis, and so we went right to the literature, and we're trying to educate ourselves about the most appropriate and effective treatment, and it was a full-time job, and it was pretty overwhelming. So I wonder how we can expect people who have limited time or perhaps a limited understanding of biology to really become informed consumers. Is this realistic, and are there some ways to educate people?
I'd like to have a go at that, if I may. I think, and I'm jumping over a few steps of the argument here, because we haven't had time, obviously, to put our full case. But I think the basic underpinning of any healthy, well-functioning healthcare system is, first of all, a media that is honest and informative and non-exploitative, and also not owned by particular corporate or other special interests. That's one thing. The other thing I think we need is a political system that is also honest and not beholden to particular corporate interests. And I think before we start talking about any of the specifics of healthcare, those conditions need to be in place.
So then we get back to how realistic is it?
Now,
realistic, well, yeah.
I can offer something here, and that is, just to reiterate, a financing system that insulates people from any of the economics of their health care, renders them impotent, passive recipients of other people's decisions. That has enormously discouraged people from becoming active partners in their care. Another sort of related thing is that, let's say, the example of antibiotics and so forth. When somebody's got, you know that you're going to swipe a debit card from your health account or whatever it is at the end of this visit, all of a sudden you do have a reason not merely to listen when the doctor says, you really don't need antibiotics. You have a reason to ask, do I really need antibiotics? And be more receptive to the doctor's education. Docs that I know have tried very hard to persuade patients, but only the ones who are economically insulated, that you really don't need antibiotics. And tell you what, how about if I write you a script, but it's dated 3 days from now, and if this is not, resolved or getting better in 3 days, which a viral illness usually will, then take it, so you don't have to come back here and go through the extra fuss and feathers. Something very interesting, just to sort of put a cap on that I heard from an executive in, I think it was Pacificare, which is a large health plan. And years ago, they actually had something kind of like health savings accounts and so forth for some of their Medicare people, okay? Whether they would have kind of a medical savings account, health savings accounts, but where that person would have a lot of responsibility up front, but with an account from which to draw the money, but the reward of keeping money in the account, if they didn't draw excessive amounts of money for useless things, this guy said, and this is ordinary elderly, okay? Spectrum, not just the highly educated retired college prof, this is everybody. He said those were unquestionably, in his experience and with the providers that he worked with, and this was an HMO system, far and away the most engaged, most informed patients of anybody in their whole system, which included everybody from babies on down. So for the Medicare folks, for this sort of Medigap policy that featured this personal responsibility, those were the folks who were very active and very informed. And he said, surprisingly informed. I think that we will find that people are not as dumb as we assume sometimes that they are. Or as indigent, indifferent as we sometimes assume them to be, or as helpless when you give them a reason not to be.
And I also think it's important to keep in mind the sorts of, at least for me, personal responsibility that I'm advocating. I certainly don't think if you're diagnosed with rheumatoid arthritis that now you're responsible for figuring out what the best program is. I understand why you're doing that, but I don't want to say that that's now the patient's responsibility. Similarly, if you have severe depression, I don't think it's your responsibility to figure out how to cope with that. I mean, that's why I think we do have professionals. On the other hand, I think you can educate yourself on what's reasonable to expect. You can educate yourself on the basics of what's required for good mental health. 8 hours of sleep a night, a balanced diet, a program of exercise. You know, all these are very important components. And it's always surprising to me how many people don't do any of those things and then feel like crap and then go to their doctor asking for a pill to help fix that problem. And those are the people, what I think he would say are the mildly depressed. Those are the people I would urge to take a second look at your own circumstances and see what you can do to fix it before you expect someone else to give you a cure.
You know, it's a very good question and very legitimate. I've been starting to sit here thinking what to advise you because, you know, as a physician myself, I do try to be as knowledgeable as possible and just pass on everything I know to patients. But I have a few words of advice. One would be, I think that patients do have some responsibility for wanting quick fixes. And I would say in general, don't be looking for quick fixes when you go into the doctor because everything has its costs. There's no free lunch. And particularly any treatment that's pharmacologic or surgical, the more invasive a treatment, the more likely it is to come with risks. So I would always want to know in getting my own health care, what are the alternatives to drugs? What are the alternatives to surgery? When I see so many patients who have hand surgery, back surgery, and matters are made worse, the more intrusive a treatment, including medication, the more likely there are to be adverse consequences. So don't be looking for quick fix. With regard to medications, how new is the medication? Is this an old, tried and true medication where I can get really pretty reliable information? By the way, guess what old means? 30 years. 30 years or more. That's how long it takes for all the side effects to really sort of come out in a new class of drugs. So is it old and tried and true, or is it kind of the new kid on the block? One thing you have to understand is that 4% of the FDA's budget is allotted to monitoring long-term safety of drugs after they're approved. It's the big gaping loophole in drug safety in this country. That's what all the congressional hearings were about. That's what David Graham from inside the FDA was saying. It's not going to be remedied. It's too political. You know, there's just too many people who don't want that loophole filled. But the FDA's mandate is upfront, minimal demonstration of efficacy, minimal demonstration of safety. So one thing I always want to know when I'm being offered something is this new, largely unknown what the risks are, promoted as risk-free because they're unknown. So those might just be a few guidelines for what I think is a very legitimate question.
Thanks very much.
Next question.
Hi, my name is John. My question's primarily for Sam, but I'd welcome comments from others as well. I think most people would agree that there's some biological component to depression. Do you think there will be an unequivocal biological test to measure the biological component eventually, much as there is for other disorders such as diabetes or heart disease? Do you think this will be an accurate metric for severe depression? And do you think that these tests, if they're eventually available, will eliminate a lot of this debate as to whether someone should get a prescription for an antidepressant? And do you think this will happen within this century, if such a test
Okay,
will be available?
it's a big question. Okay, so I'll try to answer it. First, as far as the diagnosis of depression, if it's severe depression and you're a trained person, I think you can diagnose depression with extraordinary reliability. By reliability, what I mean is that if you take a number of trained people and have them see people, they will say, yes, this person, 98% of them will agree that this person has severe depression. So that even though it's phenomenologically based, there is high reliability in making the diagnosis of severe depression. So it's not like it's a complete mystery and people can't figure it out. Good psychiatrists can diagnose it. They might start disagreeing as you move down the spectrum to what they call dysthymic disorder and milder depression, et cetera. But with severe depression, It's a pretty reliable diagnosis. Now, will we find the biology for it? That's a long and complicated answer, but from what we know right now, there is no single simple biology for it, just as there's no single simple biology for other diseases. Like even diabetes, you can get type 1 diabetes, type 2 diabetes, you can get it for autoimmune reasons, you can get it because you're too fat, you can get it for genetic reasons, you can get it for environmental reasons. So even diabetes, which is a very easily diagnosable disorder by just measuring sugar in the urine, the etiology and pathogenesis, that is the causes and the way the body responds to these causes to make the disease, are complicated. That certainly is going to be true with depression. We certainly know, okay, now let's get to genetics and biology. Okay, there's very good evidence that major depression has a genetic component. I won't go through all the evidence for it, but that is, it is what's called in simple terms substantially but not totally heritable. That is to say, if you have an identical twin with major depression, you have a very high risk of it. If you have just a brother, your risk is higher than the general population. If you're in the general population, though, it's not trivial. And there's a lot of, okay, so now there's a lot of effort being made to find the genetic variations that lead to or that predispose people, because it's not a simple genetic thing where you got the gene, you get the disease. It's complicated. There's a lot of effort being made to study this. When will substantial progress be made? We keep hoping soon, because genetic technology keeps getting better and better and better. And just generic genetic technology, that is our knowledge of the sequence of the whole human genome, is now available online. I mean, the dictionaries of the common variations within the whole genome, and it's in these variations that we will find the propensities to all kinds of diseases are being documented and accumulated at a very high rate. And certainly within 5 or 10 years, we're going to know an enormous amount about that. So what one needs to do is take very large numbers of people, thousands and thousands of people, who are wonderfully clearly diagnosed with major depression, and go through their entire genome. And when one does that, which is going to be feasible, technically feasible, and affordable, it really is now, but within 5 or 10 years, we certainly are going to find some genetic variations that will give us some clues as to what's going on. Now, will that lead to proper medications, et cetera, remains to be seen. We know about genes that cause certain illnesses, that cause Huntington's disease, for example. We know what the gene is, we know what the genetic variation is, and yet using that information to find a treatment, a pharmacological treatment, a cure, et cetera, is really very difficult. With, you said 100 years, did you have, or you said?
Or so, yeah.
You know, I think that I'm optimistic that a path to solving the genetic piece of the vulnerability to psychiatric disorders is achievable in the foreseeable future, 5, 10, 15, 20, 25, I mean, not thousands. It's not an unsolvable problem. But, you know, how it's going to work out, how valuable it's going to be for diagnosis and for treatment still remains to be seen. But the path to going forward thoughtfully and scientifically is clear.
And I guess people who may not necessarily be genetically predisposed to depression could still get it.
Yes.
Could still get severe depression. I'm wondering if this biological test, whether it's an MRI or you know, some sort of imaging or biochemical test, which currently doesn't exist, could be used to say, well, yes, you are severely depressed. Well, no, you're not severely depressed. Maybe you shouldn't. Do you think these tests will eventually be implemented?
Well,
in your opinion?
I mean, we have really good examples of this already in the case of, say, breast cancer. About 10% of breast cancer is clearly genetic in the sense that there's a major genetic variant that predisposes people to breast cancer. Incidentally, if you inherit that genetic variant, you don't have a 100% chance of getting it. You might have a 60% chance of getting it, which is a very, very high risk. But remember, you have a 10% or an 8% chance of getting it. Any woman has this huge baseline background chance. But there's a lot of breast cancer that's what's called sporadic. It doesn't run in families. There's no gene that's been identified. I think that's going to be true for psychiatric disorders too. There are going to be ones where the genetic underpinnings are identifiable, and others where it's going to be really hard to know. And certainly environment, circumstances, upbringing, chance, accidents in the way your brain gets wired up, because a lot of it is self-assembled, and it's not, you don't have somebody soldering everything in the right place. It's kind of a little scrambled. I mean, all that kind of stuff is going to be involved in vulnerability to depression, as it is for other disorders.
Thank you.
Well, I think I might have social anxiety because my heart's racing fast and my stomach's constricting.
I have a
so-
prescription pad.
Okay, I might need that.
Get free
And-
samples?
That's right.
My name's Alexa Casey, and I'm a clinical psychologist. And my question, I have a lot of parts to it, and hopefully it'll all come out and it'll be clear. You had mentioned earlier about being an informed consumer, and one thing I thought of is just I think something that you'd mentioned about the media in terms of what we see and what we hear about, and I think about where like thinking about the pharmaceutical companies and the power and influence that they have. For example, I visited a doctor's office, and when I went there, they had a whole entire spread of food and all kinds of good stuff that the pharmaceutical companies had provided to this doctor's office. And obviously that has some influence. And I guess it's how do we deal with that? Because it's big. I mean, it's really big. I mean, the amount of money made on medication and the idea that that's what you need and that's what you should be doing really it's such a huge impact. And also, the other issue that I am thinking about is when a person comes into my office and says, I'm bipolar or I'm this, their identity is wrapped up in this is what I am and this is what I need. And it's really hard to it's hard to go against sometimes the idea that they maybe can try other means and other ways of handling it. And also just the whole idea of environmental toxins, additives in food, all of those other things a lot of times are looked at like, oh, well, that's non-essential, that's not important. So the message in terms of who's controlling the dialogue and how we look at it very much is influenced by the pharmaceutical companies, and I just want to give one other example. There's a person out there called David Stein, and I don't know if any of you have heard of him or not, but he's written books about dealing with ADD, ADHD without medication, and he's not, and he's done research and he's looked at this, and it's not really accepted in a larger community that you can handle that problem without medication a lot of times. So what I'm trying, I guess my question is, how do we overcome that identity that people have that I'm bipolar, I'm this, and have the dialogue a little bit greater about other factors and other causes, because the media certainly plays a huge influence on what people understand and what they hear about. So. Does that seem, is that a question?
I think there's one in there somewhere, yeah. Yeah, I think the problem is a very long-term one. I think it was John Kenneth Galbraith who said that it's mistaken to believe that the market meets pre-existing needs. Rather, the market very often creates the needs. And we certainly see this happening in the case of the pharmaceutical industry, but I think it's a much more general problem throughout society. And it's a long-term one because the self is in some ways reconstructed to fit a particular sort of market. So in some ways, the very structure of personality is created by the economic world. Now, that's not something that's easy to address, any one of us individually who are born into this situation. So I think we have to look to the long term and think constructively and critically about the sort of society we want to live in that would meet real human needs rather than trying to fit into those created needs that have been produced in this commercial way.
I'll give you a little example. You mentioned bipolar. And I said earlier that in my estimation, we're right now witnessing the kind of marketing of bipolar disorder to market drugs. So what do I mean by that? If you take too much cocaine, if someone takes too much cocaine or too much amphetamine and looks high, looks manic, and ends up in an emergency room, they will be diagnosed with cocaine toxicity or amphetamine toxicity. If the same thing happens from a prescription antidepressant, when they get into the emergency room or the doctor's office, they will be diagnosed with underlying bipolar disorder that was brought out by the antidepressant and given new medications. Now, there's actually quite a lot of overlap between the mechanism of action of cocaine and the mechanism of action of our contemporary antidepressants. And in fact, if you go to the DSM, which was talked about a little earlier, the diagnostic Bible in psychiatry, and you look up bipolar disorder and you look up what's called the differential diagnosis of bipolar disorder, you'll find several paragraphs there that specifically say that someone should not be diagnosed with bipolar disorder solely on the basis of a reaction to a medication, whether it be an antidepressant or a steroid or cocaine. But that is happening over and over and over again to countless people in this country right now. And a lot of people are being told you have bipolar disorder because they did get a little revved up, a little overstimulated, perhaps because it was too high a dose or because they're super sensitive to the medications. Almost all of the currently prescribed antidepressants, if you go and look in the physician's desk reference at the pharmaceutical company's official information for the drug, they'll almost all have a warning or a precaution that the drug can trigger bipolar disorder. And there's a very strong push to see patients who are put on antidepressants and look manic. I call it manic-like because it's not genuine mania. It's not the same thing as a de novo mania, not under the influence of a drug. So again, I think you have to be really well-educated consumers. Don't just buy into labels. If you're a clinician, if you're a therapist, seeing people that you feel this is happening to, you just do the best you can to try and help point them towards resources that would help them educate themselves.
We have two more questions.
Hi, my name is Pam. First, I want to thank Dr. Glenn Mullen in particular for your book, Prozac Backlash.
Thank you.
Which is helping to change my life. And I do have a question which I want to direct toward Dr. Glenn Mullen and to Sam in particular. At first, I do want to say I stand before you with a bit of a warning because I was one of those teenagers who at the tender age of 15 was told you have a biochemical imbalance, which is at that age pretty hard to hear and pretty hard to process. I believed it because, like you said, youngsters are more impressionable and more usually willing to accept what authority is saying. At least I was for a long, long time. Many years have passed, and as an adult now, I find myself with a lot of unanswered questions. The warning that I was referring to, which I'm going to relate to the question, is that I was on antidepressants for 8 years or so and made an attempt to taper off them under a doctor's care at one point. That was the first time, and then much later in life, after about 11 years of being on Effexor, I tried again to taper, most unsuccessfully. In fact, I had a backlash of my own, which you were just describing people going to the ER and having, I think you said manic life or a sort of pseudo mania where they don't have that underlying disorder, but they're either on antidepressants and that boosted up their chemicals too high so they experienced some manic symptoms, or in my case, I had the opposite. I went through withdrawal, and it was a course of, say, 8 weeks of pretty bad physical effects like nausea, fatigue, muscle pain, dizziness, electric shock sensations in my temples. After about 8 weeks, it developed into the psychiatric backlash, which I won't even go into describing that. But unfortunately for me, the first time this ever happened to me, I was under a doctor's care who had not really known me that well, only looked at my file and knew that I had a history of depression. And I was misdiagnosed am mislabeled as bipolar because of my withdrawal. And it was, clearly, in every way. It looked like it did. It looked and felt like mania. Only I don't believe it would have happened if I hadn't have had years of being on this medication and tried to come off it. That's the warning. And doctors will tell you it's safe. I just came out of another room here, another conference, and doctors will tell you it's safe, non-addictive, and all this. Either they're lying or they simply don't have the knowledge. And you can't really blame them for not knowing what's going to happen to you 10 or 20 years down the line once you've been on this. However, I think maybe a mistake was made in that it was never suggested to me by any doctor along the way, perhaps you should try to come off this medicine. Perhaps we can taper you. Perhaps we can monitor your life. Before I became, I think, habituated. That's the question I want to ask. In your book, Prozac Backlash, you ask the question, what if long-term use of serotonin boosters sensitizes brain cells such that they cannot function without it? That really piqued my interest, and I'm wondering, what did you discover? Can that question be answered, or what did you discover in your research?
Sure. Well, first of all, thank you very much for being so open and sharing some of your own story. Secondly, today's antidepressants, which means all the SSRIs, Prozac, Zoloft, Paxil, Luvox, Celexa, Lexapro, the SNRIs, Effexor, Cymbalta, Wellbutrin, which is kind of atypical. Withdrawal was another of the controversial side effects of these antidepressants. Certainly in 2000, when I wrote Prozac Backlash and had a whole chapter on it and alleged that to varying degrees they could cause withdrawal. I put that in the past tense because I don't really think there's a debate over it anymore. I think that it's widely acknowledged that these drugs cause withdrawal. It is to varying degrees, so your particular example was Effexor, which is by far one of the worst, if not the worst. And we now know, oh, by the way, the new book, The Antidepressant Solution, is specifically on this. It's a tapering protocol because so many people asked, well, how do you deal with this? And there's a table, you can actually rank order them in terms of how often and how severely they cause withdrawal, and it's correlated with what's called the half-life, which is how quickly the drug washes out of your body. And basically, if you stop a drug with a short half-life of just a matter of hours, cold turkey, it's going to wash out of the brain so quickly that the brain cells, which have adapted over years often to living with the drugs, just don't have adequate time to dismantle their adaptations and re-equilibrate to living without the drug. The key is to taper slowly. What does that mean? Well, for some people, the more common, Effexor is not prescribed anywhere as commonly as Paxil. So Paxil, even though it has a little bit longer half-life than Effexor and not quite as bad as causing withdrawal, it affects a far greater number of people. So that's sort of the prototype drug for this particular side effect. And if you take someone on 20 milligrams of Paxil, which is a fairly standard dose, some people can be off in 4 weeks, and other people it may take 8 months. So that gives you the enormous range of variability based on individual sensitivity to withdrawal side effects. And the key is to use a tapering schedule that's not fixed. You don't say at the outset, we're going to spend 8 weeks getting off this, or 16 weeks. You have a tapering schedule that's flexible all along the way to keep pushing it out if the withdrawal symptoms indicate that that's what's needed. I don't know if you're still on Effexor. In my experience, I've always been able to get people off the drugs, but sometimes they're pretty uncomfortable for very long periods of time. But if they're motivated and willing to deal with that discomfort, I can get them off. Another buzzword of controversy that you used is the word addiction. So these drugs were actually heavily promoted as not being addicting. And it turns out, I didn't really appreciate this until very recently, that part of the marketing strategy was to undermine and supplant Valium-type anti-anxiety agents. Now, I mentioned earlier that it takes about 30 years for the full lifespan of a drug's side effects to come out. I talk about 10, 20, 30-year pattern. After about 10 years, we have kind of the earliest signs of what might be the worst side effects. After 20 years, we have pretty definitive evidence. Again, this is because there isn't systematic monitoring of it. And then it takes about another decade for slow bureaucratic regulatory agencies and professional organizations to actually change prescribing patterns. But if you look at it, that's also the period in time in which it takes for a new class of drugs for them to all go off patent. And at that point, the companies are no longer invested in the drugs. They're no longer fiercely defending the drugs. They're no longer denying the side effects. And there's very good evidence that in some instances, they actually turn on the drugs and try to use the side effects that they previously denied to undermine them to make room for the new patented whose side effects aren't known. So just to say one word about addiction, technically, medically, people are not addicted to antidepressants. But it turns out that's because the technical medical definition is set up to require using doses recreationally, just to kind of describe it simply. But in common parlance, in plain English, when people can't get off Paxil for 8 months, they will say they're addicted. And I could show you a BBC expose that's absolutely brilliant where the head of European GlaxoSmithKline admitted that they should not use statements that Paxil isn't addictive. They took it out of all their official information. It's one of the more controversial areas, but the bottom line is people, patients, plain English, will use that term, even though it's not the medical term.
Well, in my case, I did not, I should say, in coming off the drug or withdrawing, I never had a sense of craving anything. I never had the thought, oh, I have to run and get a bottle.
Right.
It wasn't like that.
It's to relieve distress.
It was just all the physical pain, you know, from coming off it and the changes in brain chemistry from coming off it. So I think you quoted Ian Oswald in your book, and he described antidepressants as drugs of dependence, although not of abuse. So that kind of clarifies.
Very good.
Thank you. We have one final question.
My name is Richard. There's an old saying, if all you have is a hammer, everything looks like a nail. The hammers we've been talking about are the SSRIs. What's the next hammer that some ad is going to tell me I ought to ask my doctor whether it's for me? What's in the pipeline by way of these sorts of mood?
I'll tell you
These
what.
technologies of mind. Is
Deep
what
brain
I'd like to-
stimulators and vagus nerve stimulators. We're looking at the device market.
I'm sorry again?
Devices. Deep brain stimulators, vagus nerve stimulators. I'm not ruling out drugs, but something that's definitely moving forward now is the device side.
Hi, I'm Carol. I'm a sociology professor, and I know the audience doesn't always hear what we as speakers say, so I want to get clarified here. I thought I heard you say that if people were responsible for their own medical care, had to pay for it and make decisions based on economics, they would get better care. They'd be more responsible. The sociology literature says the 35 million people who are underinsured, the people who don't have the $25 for the copay, don't somehow end up better. They go without care. They go with lousy care. You said the employers can put $1,000 into your tax-free. You don't have money to do that if you're the working poor, if you're on minimum wage. And so I was disturbed, so help me out here.
I emphasize the caveat that I put in several times, if properly done. I would not begin to say that, oh, well, the way to make people responsible is make them shell everything out of pocket. That's not the message. And again, that's not the topic here, but the idea is that if you can put people into contact with the economics without creating financial barriers to care. You're talking about financial barriers. Very different, and I agree with you, not something we want to erect. But if you can place people into economic contact without creating financial barriers to care, you can then create a much more liberated situation where it's my doctor and me, not my doctor and me and 1-800-NURSE-FROM-HELL and somebody else trying to dictate what we get to talk about and what we get to do. That's what I'm talking about. I thank you for the opportunity to clarify.
Well, I'd like to thank our panelists for a very stimulating couple of hours and the audience for your participation as well. We will adjourn now for a lunch hour, and there will be small panels following later in the afternoon. Thank you all so much.